So, as we look at Breech, I think during a word round, we had already talked about Breech. Do you want me to quickly go through, or I just go straight to the manual?
Quickly go.
Due to time, because of the presentation at 12, we just have about roughly 20 minutes.
Okay. What I will do is I'll write for you somewhere. But I didn't somebody take note. Okay. When we have time, what I will write is we need to look at Breech in terms of definition. I'll just talk about the subtitles. So definition, what is Breech? Okay, we know that it's a malpresentation in which the fetus presents with either the buttocks or the foot. So it means two things, the fetal buttocks or the feet. In terms of the types of breech, we are saying that the first type of breech is called a flexed breech. A flexed breech is one where there is flexion at both the hip and the knee. So the baby is this way and that way. That's called a flexed breech, with other names like a full breech or a complete breech. But we'll write that, don't need to start writing. The other one is where it's flexed on the hips but extended on the knees. And that one is called a frank breech, or also called an extended breech. There's a chair here. The third one is where either one foot is down like that, notwithstanding the other lower limb, or both of them are like that. That's a footling breech. So those are the three types of breech. Of course, there are some further sub-classification the midwives would make. For instance, they would call a footling and an extended or frank breech as being incomplete breeches, whereas leaving the flexed breech as a complete breech. Away from that, we talked about the risk factors to a breech. Why should the baby become a breech? Now we are saying it's normal for a baby to be breeched before 34 weeks because the baby has space within the uterine cavity to rotate. But after 34 completed weeks, we get concern, and that's where the term breech strictly starts. Now, maternal causes of breech, there are several, and we'll have them written. One of them is the placenta previa. The other one could be a submucosal uterine fibroid. Those are preventing the baby from tearing. Number 3, we are talking about the uterine malformation, the structural malformations such as biconioid uterus, uterine didelphisis, and some other Mullerian issues. The other reason it could be that there is polyhydramnios and the baby is just rotating and has unstable lie. The other one could be preterm labor because it has caught the baby breechy at 30 weeks, right? And several other reasons like prime gravidity or grand multiparity, and so on and so forth. So those are some of the risk factors for breech on the maternal side. On the fetal side, number 1, which you should even worry most, is congenital fetal malformation. This baby is not okay. It has got hydrocephalus, it has got a sacrococcygeal tumor, and no wonder it's not turning and listening to the body. Number 2, it could be that this baby is dead. A dead baby cannot make movements. Okay, number 3, it could be a short umbilical cord, and many other reasons. So from the risk factors, we've now got to applied anatomy. We are saying that under applied anatomy, there is this diameter. There's also this diameter, and there's this diameter. So from below upwards, we are talking about the bitrochanteric diameter. So this baby, as it's coming out of the mother's pelvic cavity, it will first come out with the legs. So it will pass through the bitrochanteric diameters, the distance between the greater trochanters of the femur. Then the next, they will meet the acromion processes of the scapula, and that will be the bisacromial diameter, and then it will conclude with a biparietal diameter. And we said of these three diameters, the most important one is the biparietal diameter because it's not easily manipulatable. For the bisacromial, the baby can do this. You can even manipulate it, and as you shall see some of the maneuvers, for instance, in a condition known as shoulder distortion. That is some of the maneuvers we use, like the Rubin tool, the Wood's corkscrew, uses the manipulation of these diameters, despite looking wider. And then this other one. In terms of, again, other aspects of applied anatomy, we need to look at the denominator. A denominator is a leading part. So for a vertex presentation, it's the occiput. The occiput is the leading part of a vertex presentation. So the occiput can be like this, can be tilted that way, it can be like that. So that occiput is a bony prominence. So the denominator is always a bony prominence. That is the leading part of the presentation. So you've got a presentation like the whole cephalic vertex, but on that presentation there's a leading part, which is a bony prominence, and that's what the denominator. So you can't talk about position without a denominator. No wonder we talk about left occipital anterior, right occipital anterior, direct occipital anterior, occipital posterior, and things like that. For the first presentation, we talk about the mentor. For the brow presentation, we talk about what's called the sinciput. But for a breech, the leading part is the sacrum. So the positions we have are sacro anterior, sacro posterior, and the best is sacro anterior. If I was a mother, but I don't have a uterus, I would rather this baby is facing my back. It is easier to deliver such a baby than a baby facing me. It's facing the same direction. And that's why we talked about the modified Craig maneuvers, which I hope you read on. If the baby is like this, because you can't deliver the head in this orientation. Away from that, we talked about mechanisms of labor. So just like cephalic, there are a series of passive movements undertaken by the fetus as it passes through the bed. And now, remember, we have descent, engagement, further descent. Then what does the baby do? Because the baby is usually in this orientation. It will flex. Then when it flexes, it will go into internal rotation. Then from internal rotation, it's extension on the pubic symphysis. Then external rotation. But before external rotation, we have in between what? Restitution. And then external rotation, and then you deliver. So those are mechanisms for a vertex. Descent, engagement, further descent, flexion, internal rotation, extension, restitution, then external rotation. So even for breech, it also has its own mechanisms. But we rarely emphasize on mechanisms of labor for breech because we do a lot of manipulations. For vertex, we don't manipulate the baby. The only thing a midwife does is basically external rotation. Because the baby does this on its own. The baby restitutes itself. The midwife just completes the external rotation. No wonder we'll emphasize on the previous maneuvers. But for a breech, we rarely allow the baby to come out on its own. It can come out on its own if it so wishes. But we don't emphasize on the mechanisms. Finally, but now I don't want to lecture everybody. I finish, Should I finish?
Finish.
Very quickly. So we talked about the symptoms. So the symptoms of the breech and its signs are not different from one with cephalic. But one of the things we need to know is that meconium passage in breech is normal. Okay? So if a woman tells you, as she's complaining of intermittent no abdominal pain, backache, sore, draining, and she says, I'm draining what looks like green. Like, green is like, what happened? That's why. Avocado. So you shouldn't panic because it's normal. The other issue is when it comes to the signs. When you are palpating the abdomen in one who has a breech, because the baby is like this. So this soft, broad, irregular mass, which is normally felt on the fundus, will be felt in the pelvis, right? It will be the opposite of what you normally get on the cephalic presentation. Number 2, you find that the fetal heart is best held at or above the level of the umbilicus. And I even mentioned, say, experienced midwives, even if both of you are failed to locate what is in the pelvis, experienced midwives will locate where best the fetal heart is held, and they'll tell you that this is a breech. Okay? Then I mentioned that you don't comment on descent for breech. You can't say, descent is 3/5. So that goes even on the pathogram. If you are monitoring remember in a breech, there's no way you can have the part for the descent. It will just specify dilatation on that graph. Descent of fifth palpable is only for cephalic. When it comes to vaginal examination, equally, for breech, we do not comment on station. You can't say -2. So from that Caesar that was born, I was saying the presenting part is high, and I agreed with her. She didn't say it's -1 or what, because it's a breech. Okay, that's one. But you can comment on the position, sacral anterior. You can comment on other issues. Then we talked about complications of breech. What are the complications of breech? We said they can be maternal or fetal. So the fetal complications of breech are mostly at delivery, as you shall see. One of the complications of breech is cord prolapse. Cord prolapse is common in footling breech. No wonder a footling breech should be a cesarean section start, because the baby has spread the legs and the cord here will pass in between. So if they tell you cord prolapse in a breech, it's almost always a footling. Number 2, prolonged labor, because a foot, the design of a foot can't be compared to a rounded head. So labor will take long. Number 3, it will be at delivery. If you don't do maneuvers properly, you can fracture these lower limbs. Femur, tibia, fibula. You can dislocate these joints. That's one. The other issue is, as this baby is coming out, you find somebody is holding this. What are you going to do? Visceral injury, splenic rupture. What else? As you are trying to pull the baby, the umbilical cord can snap, or it can be compressed, or it can prolapse. All those are called cord accidents. Next, you find that as you continue, and the baby is out up to here, and this is a very important stage of delivery of the breech, especially if the hands are extended. So all you are seeing in labor ward is this. The physician has not given me a correct model. So these are out, but you can't see the shoulders. If you don't deliver this stage properly, like what I was saying, you find people are trying to do this so that they deliver this shoulder and then pull up and deliver the other shoulder, as if they're delivering a cephalic. Because in a cephalic, that's what we do. The baby will be like this. So you go down, you deliver this shoulder, anterior shoulder out, then you up, then you deliver the posterior shoulder. That's how the baby comes out. That is for cephalic. You can't do the same thing for breech, where you want to do this baby like this, then baby like that. Do you think the baby can come out on this diameter? It's too wide. So no wonder the risk of doing this undue abduction of the head from the shoulder will cause the disruption of the trunks of the brachial plexus, and the baby will end up with the Elb's paralysis. You just find the baby when you are going in town walking like this. That's a Porter's tip hand vomit. Okay, so brachial plexus injury is another complication. The other complication is the last one, is where the baby comes out, but then the head is stuck. And that's called the stuck after coming head of breech. Stuck after coming head of breech. Or head entrapment. of breech. So that's a horrible complication. It's even worse than shoulder dystocia, because shoulder dystocia is only this which is stacked. This is more, probably you can even do the Zavanelli maneuver and push the head back and do a scissor. But do you think you can do a scissor when this is out? Maybe experience before like Dr. Mulenga, you can manage to pull this baby through the uterus. So in other words, almost always you have lost this baby. Unless you are going to do what are called Dussen's incisions, or you are going to apply what are called Piper's obstetric forceps to have this head come out. So those are some of the issues. Okay, what are the maternal complications? So maternal complications, number one, it could be that there will be risk for PPH. Why risk for PPH? But PPH is a postpartum problem. Let me start with psychological trauma. If you are putting the baby like this, mommy push, mommy push, she's seeing how you are pulling the baby's legs, she will be traumatized. So in most cases, do what we do in theater there. Let her not be seeing what you are doing, because she feels like you are stressing her baby. So her mind will not be listening to your instructions. Her mind will be, what are they doing to my baby? Those look like the legs of my baby. You get the point? So you need to do that. But the other issue, more importantly, is that there's risk for PPH. Why? Because of genital tract injury. If you don't do these maneuvers properly, you are going to injure the genital tract. You end up with third-degree vaginal tears and other type of things. Yes, and so on and so forth. So that is the main problem for the mother. It's just basically PPH due to trauma. Differential diagnosis, what might look like breech when in fact it's not. One of the things is an engaged baby. Because when the baby is engaged and this head is in the pelvis, you'll be getting the shoulders, feeling like they are broad. And the people will be thinking this is a breech. Number two is multiple pregnancy. You've got twins, triplets, and you really can't tell multiple fetal pods, right? The third one could be that you have a fibroid within the uterine cavity, or be it intramural or submucosal or indeed subserosal, and then it might look like it's a breech. Finally, investigations. What investigations do we do in a breech? Just two things: full blood count and an ultrasound scan. Right? Delivery of a breech, and that's where we are now. So a breech can be delivered spontaneously on its own. It can come out with or without your hands, and that's called spontaneous breech delivery, and it's not recommended because it means the baby has used its own mechanisms. The second is cesarean section, but we said the cesarean section is restricted for 6 conditions where it's a scissor start, one of which is a footling breech cesarean section. The second one is what is called a big breech. A big breech is a breech with a weight on scan of more than 3.5 kg and with a biparietal diameter of more than 9 centimeters. Much lower thresholds compared to a cephalic. You get the point? Because we want to be on the safe side for breech. 3.5 kg, 9 centimeter biparietal diameter. The next one is what is called an undiagnosed breech. What do we mean by an undiagnosed breech? A breech where you have not done a scan. Meaning you don't know the possible cause, one, and you don't know what is called the fetal attitude, the degree of flexion of the fetal head. This is a very important aspect of a breech delivery. Because if the baby is deflexed, you would have delivered very well, but you failed to do a maneuver known as the modified Moricel-Smale weight, because your fingers will be reaching the neck. Because you've upset the baby. So the baby has deflexed. So if I don't know how this flexed this thing is, or I don't know the possible cause. Because what if it's placenta previa? What if the cause is a hydrocephalus? What will happen? That's a disaster. Because we would have delivered the baby and there's a big head. And the baby is alive and it's even doing the legs like that. That baby, that will be the end. Because you can't do destructive operation on a live baby who could have just gone to have a ventriculoperitoneal shunt or endoscopic fed ventriculostomy by the surgeons. And that would have lived a normal life. But then you are stuck with that baby. You get the point? So, for us, when we say undiagnosed breech, we are referring only to two aspects. Because the rest, in terms of the weight, in terms of the type, in terms of other aspects, can be felt clinically with continued practice. But the attitude and the cause requires a scan. The next is what we call a breech in previous cesarean section. So if it's a previous Caesar breech, equals a Caesar. Next, breech in a prime gravida. Caesar. Breech in twin 1, cesarean section. And finally, breech with another obstetric complication. For instance, breech in severe preeclampsia. Breech with another something. Okay, so that is the issues of cesarean section. The other way in which you can deliver a breech, I don't know if that's the third way, is by external cephalic version. Meaning that the baby is like this, you diagnose it antenatally, then you can turn the baby abdominal so that it faces cephalic. Then you deliver normally as a cephalic presentation. That's called the external cephalic version. I know you have never observed one. Because some of the things we used to do in obstetrics have fallen out of favor. People have stopped doing them. And then we also have another one known as the total breech extraction. So total breech extraction means that when you go in, you come out with the baby at once, without a break. Exact thing that you do at cesarean section. Because at cesarean section, you can't ask the patient to push. You go in and you come out with the baby. That's what we call total breech extraction. So, vaginally, we use total breech extraction when we are doing internal podalic version, where twin 2 is the transverse. So you keep the membranes intact with your hands. While using the membranes, you go for the feet. First of all, of course, I'm not talking about twin pregnancy. That's a discussion for another day. So I've skipped some steps. But you go in with your hands, grab the feet, then turn the baby and convert the baby from transverse line to longitudinal line with breech presentation. Without letting go of this, you pull out the baby, but using the maneuvers, which we shall discuss, and that's called total breech extraction. That's all. Now, the last one is assisted breech delivery, and that's the one I wanted to demonstrate. So, unfortunately, we had discussed this in the OBS and guide one round, but I've seen some people here and you. No wonder I was supposed to go back. Otherwise, in my mind, I was just going straight for the maneuvers. Yeah, but this is where we reached, and I know I haven't forgotten anything. So, for